Welcome to Pharmacy to Dose, the critical care podcast, where we're discussing critical care and its pharmacotherapy in a fun and entertaining manner. And I'm your host, Nick Peters. Wherever you are and however you are listening, thank you. Now, a quick word from our sponsor, QXMD, before we get into everything today. QXMD builds mobile solutions that drive evidence-based care in clinical practice. So check out READ for easy access to research personalized for you. Calculate for over 500 easy-to-use decision support tools, and Learn to earn CME online in minutes per day. Try them today at qxmd.com/apps. Again, that is qxmd.com/apps. So welcome back to our special 3-part episode on the critical care medication March Madness bracket. And I'm joined by our expert bracketologists breaking down all 67 games to ultimately find the best medication in critical care. And I need to give another huge thank you to the 4 expert analysts. This would not have been as much fun, insightful without their help. As a reminder, those 4 bracketologists are Melanie Smith, Brian Gilbert, Josiah Smith, and Matt Robertus. Yesterday, we announced them in order of regions, kind of the appearance on the podcast, and today we're doing the exact opposite. Now, the first part of this episode was released yesterday, so if you haven't listened yet, go back and do just that. I go into detail about all that went into creating the bracket, the quote-unquote rules that I gave the bracketologists when selecting medications and going through the matchups, how we settled on the 68 medications. And the best part is obviously when we get to the analysis from Matt Robertus in the CV region and Josiah Smith in the ID region. Now today, we break down the remaining 2 regions, which is pain, agitation, and delirium, or PAD, and Potpourri, with Melanie Smith and Brian Gilbert, respectively. And the final episode is going to feature all 4 bracketologists coming back to talk about the final 4, kind of pick their winner of the critical care medication March Madness bracket. Now, a reminder that if you go to pharmacytodose.com, our official website, there's a downloadable bracket that you can print out or fill out electronically. And on Twitter, we still are voting on matchups for the official listeners bracket. So find us on Twitter. It's at pharmacytodose. Vote, and then give us a follow if you're not already. So, all right, I'm ready. You're ready. I think everyone's ready. Let's go back to our analysis of the critical care medication March Madness bracket. Now we're switching sides of the bracket, going from left to right of the critical care medication March Madness bracket. And I'm joined by Brian Gilbert, the official bracketologist for the Potpourri region. Now the Potpourri region is our region that's filled with important drugs that we use routinely in the ICU, but who don't fit nicely into specific categories like, ID or PAD like the previous or future regions. Now, Brian is an emergency medicine clinical pharmacy specialist at Wesley Medical Center in Wichita, Kansas. He serves as the PGY2 Critical Care Pharmacy Residency Director, an adjunct assistant clinical professor for the University of Kansas School of Pharmacy, and Director of Education for the Kansas Council of Health System Pharmacy. Brian, thanks for taking the time. I appreciate you joining me today. How are you?
Thank you, Nick. Thanks for having me. I really do appreciate it, especially in these trying times. Everyone's losing their minds, can't find toilet paper, about to have drug shortages. So thanks for having us and doing something fun like this.
Man, I appreciate that. It's a strange time, isn't it? Sports are being canceled for the first time, I think, in our generation. And normally the first round of games is tipping off, and we have college basketball from noon to midnight for what feels like 2 weeks straight. Now, you typically like to watch the first round of the NCAA tournament where?
So usually I'm in Vegas by now, buddy. I'm on the plane, the Allegiant flight. I've already had a mimosa or two, and I am ready to hit the sports book watching these games.
Now, where do you like to go and watch? What's your strategy? Do you hit one of the newer casinos like the Cosmopolitan? Do you hit like a tried and true, the MGM, or do you just go say F it and go to Old Vegas and Fremont Street?
So I'm an MGM guy through and through. So I will typically stay within the MGM family of restaurants and sports books, and usually we'll typically start out at MGM Grand, and then we'll hit Park MGM, which is the old Monte Carlo, and then if we're feeling froggy, we'll run on down to the Mirage or the Bellagio.
How long has this been a tradition?
So, I had a preceptor from my PGY1 institution who's been doing it for a long, long time, at least 5 or 6 years, I believe. And so I've been going with him now. This would have been the 4th year. Unfortunately, this year we were shut down due to the COVID situation, and rightfully so. But, so this would have been about the 4th year, and a lot of shenanigans go down with that, and a lot of things to look forward to throughout the year, and a lot of trash talk.
Practicing what you preach, though, that's a good thing. The social distancing. I'm sure that was tough, but definitely needed. Now, you definitely live in Kansas Jayhawk country. I know that just from the intro. Now, what's it like, kind of rooting for another team when you're in Jayhawk country? Do you have to wear like a scarlet letter? Do you have like a tattoo somewhere that they like brand you with? How does that work?
So they try to, as soon as you go through the state lines into Kansas, they try to baptize you in the ways of the Jayhawk. They'll scream rock chalk and all of that nonsense going on. It's a little bit more split here in Wichita, just due to the fact that Wichita State will periodically represent pretty well within the tournament in basketball, but yeah, I would say for the most part, you've got a large percentage of KU fans here. So it's tough not to drink the Kool-Aid around here, but no scarlet letter here for me. As a Florida State fan, you gotta stay with it and stay committed, unlike some of these fair weather fans.
Yeah, with your favorite team being the Florida State Seminoles, I imagine trash talking basketball is rarely something you like to get into. I'm sure you try to bring it to football as quick as possible. Is that true?
It depends, right? So here lately, in the past few years, I've canceled football season altogether just with the performances we've had. But in the past few years, Florida State basketball has really been on the rise. This was the first year we had our first regular season ACC tournament champion. We were heading into the tournament as the number 1 seed for the ACC. The past couple of years we've reached the Sweet 16 and the Elite 8. And not to brag, but the Florida Senate just declared us the national champions here for the entire NCAA. So I've got that going for me, which is nice.
They actually made a directive. That's amazing. Yeah, it was very weird when they canceled the ACC tournament, and then Florida State was there, and they gave them the trophy as if just being the number 1 seed meant that they were also the tournament. But I take any banner you can get, right?
There's no asterisk where I'm coming from on this. We're the 2019 ACC champions, and I'll hear nothing of it. Don't at me.
Now, with everything happening with the coronavirus, most of us were going to be home more, kind of looking for things to watch. So what are a couple, or at least one, like streaming recommendation for the listeners? What are things if they're looking for a TV show or movie, where should they dial into?
So right now you've got a lot of, there's just so many options that are going in respect to content. So you've got Hulu putting out some good stuff. You've got Amazon Prime putting out good stuff. Netflix, there's Disney Plus. So it just really depends on what you're looking for. So if you're looking for a really good documentary, we're right in the middle of one called McMillions, where it was about the folks from Jacksonville, Florida, which is got to represent where I'm from, that were rigging the McDonald's Monopoly game. So it's on HBO Go. It's a really good docuseries, really interesting stuff. For Amazon Prime, if you want something that's more of a historical nature, but they take some licensing with that. There's a good show called, I believe it's Killers. It's got Al Pacino in it, where they're looking at hunting down Nazis. It's a little bit interesting. So that one's pretty good. And then Netflix has some old tried and true movies that are on there that are pretty good right now. So you've got The Other Guys, Tom Cruise's The Last Samurai. So some really good old movies that are available. If you're into the kid genre, Frozen 2 just came out on Disney Plus for all the families looking out there. So there's a lot of great entertainment across the spectrum.
I like that you shouted out Frozen 2. As someone who has never seen Frozen 1 or Frozen 2, do you have a preference? Can you power rank those two? Did you think the second was better?
So, it depends on what you're trying to look for. I think Frozen 2 had more ballads, in terms of the songs, because, with a 4-year-old at the house, you have to be able to sing along with them. And so I think that Frozen 2 was definitely more ballads. Frozen 1 was maybe a little bit more lighthearted and had a little bit more fun songs to sing. So it'll be interesting to see where Frozen 3 goes. And definitely there will be a Frozen 3. You heard it here first.
They're already thinking down to 4 or 5, I'm sure. It's funny you mentioned McMillions. Definitely sign off on that as well. But a couple of HBO recs for me. There's a great mini series that just finished up called The Outsider. It's kind of a psychological thriller based on a Stephen King book. Really good. If you haven't got on the Succession train yet, fantastic TV series that's only 2 seasons in, and then a couple classics, The Sopranos or The Wire in terms of shows if you've never seen them. So a couple HBO. I fully endorse everyone having some HBO right now if you're in need of some things to watch.
And what a great theme song for Succession! Like, what a great intro with the piano and the keys. Like, it's awesome. One of my ED physicians has that as his ringtone, and it goes off quite a bit, and it still doesn't get old. So very, very entertaining.
Oh, it's perfect. It's perfect. Now, we have the top 4 seeds in the Potpourri region: regular insulin, levetiracetam, furosemide, and then 4-factor PCC Kcentra. So what do you think? Any issues with the top of this region here?
I think for a Potpourri region, this is pretty good in terms of the seeding. I think that worked out pretty well with respect to looking at your critically ill patient populations, your use. I don't have an issue at all really with this top 4. I think they're all pretty strong. They all have their advantages and disadvantages. So if you try to equate these to what they would look like in terms of teams, I think that they are rounded out pretty well in what you would see in a typical March Madness NCAA tournament.
Now, sometimes it's even just as much fun, to talk about not only the teams that made the tournament, but obviously the first 4 out, the bubble teams that just didn't make it. So did any of these meds stand out from your perspective that maybe got snubbed that should have been here but weren't included?
One of the only ones I could really think about, and I took a good hard look at this and really thought about it, was TXA. It's one that it's not really great at anything, but it's pretty okay, good at some things. And so it's kind of like my fashion choices at pharmacy conferences. They're just not for everyone. And so I think that the TXA maybe missing the nod there would have been one that I would have potentially thought about. But I do understand it. I do get it. So I don't need a bunch of TXA haters mentioning me on Twitter about all its downfalls. I'm well aware of it.
Well, and number one, that was the med that stood out to me, and if anyone's chirping you, it's because they didn't listen to the first part of this, the first episode of this series where we talk about it. It was Democratic, so there are some meds in this region that you may not have necessarily voted for, right? But it's a democracy between the bracketologists and I, and that's how we came up with this. So definitely, don't be chirping Brian now based on some of these things. Now we start the region with the final two play-in games from the first four. So we have the battle of the electrolytes, the 15 ranked potassium versus the 18th ranked phosphate, and then the other matchup is the 17 seed sodium bicarb taking on the 16 seed octreotide. So who's making it to the round of 64, Brian?
So the bubble teams here, when you look at it, who's playing hot right now, and teams that are overall going to have the best chance of moving forward. I think when you look at bicarb versus octreotide, you got to give the nod to bicarb here, just for its overall mass utilization through all aspects of critical care. I think that's going to be one that has the potential to move forward. So we're going to go ahead and give the nod to bicarb there. With respect to the electrolytes, this is another tough one, but I think overall, when you look at use and you look at potential issues from being either deficient or in an extreme, having too much in that situation, I think you have to go with potassium here. So too many issues for hypokalemia not to put potassium replacement in there. So I got to go with potassium and bicarb.
Yeah, the bicarb octreotide matchup, what a first four kind of battle. I could see both sides of this argument. You know, the only playing contrarian a little bit here, the only thing would be, you know, octreotide could just, it's like the utility man. He can play 1 through 5, and it can kind of do a lot of things. So it is kind of the Swiss Army knife, but just with the overall kind of mass utilization, I agree. I think in the end, bicarb was just a little too much.
You know, you look at it and you think octreotide's probably the winner of the NIT. So nothing wrong with being the 65th place team.
All right, so it's Thursday, and I think we're going to pretend that you actually made the trip to Vegas. So you're in the sports book, bets are in, let's get going, and we definitely start off with a bang here. So we have the 3 seed taking on desmopressin, DDAVP, the 14 seed. And so who wins this matchup?
So DDAVP versus furosemide. So I took a really hard look at this, and I really was thinking where we would go with this one. And I'll be honest with you, the Thursday and Friday games are known for upsets, right? So we see the Cinderella teams. And so DDAVP, with a lot of the emergent data that's coming out right now with its use for antiplatelet-associated coagulopathies and reversal, especially in intracranial hemorrhage. It's used for all the other neuro injuries as well, in terms of retention of fluid, as all of that. I think that you got to go with DDAVP here. It's not a team that you want to play. It's a medication that's really hot right now if you look at all the emerging data. And furosemide's that tried and true team that definitely is going to be very predictable. And so they didn't match up well with DDAVP because they didn't change their game plan. So we're starting off with a bang.
Wow.
Upset alert, going with DDAVP, the winner. 14 seed taking them down.
Biggest upset of the entire tournament thus far. Wow. So I guess if someone comes in fluid overloaded, we're just popping dialysis catheters in, huh?
Oh wow, yeah. If they're uremic, you're gonna need a little DDAVP because they're gonna bleed. So there, boom! I just beat you at your own game.
Okay, I'm definitely still kind of catching my breath over here, but we the next matchup it's the Great Steroid Showdown. And no, this is not 90s baseball. We're talking here NCAA tournament, the 8-9, the number 8 methylprednisolone playing the number 9 hydrocortisone.
No, another great matchup, very evenly matched. Looking at the different opportunities for utilization in critically ill patients. I think that overall, though, you got to give a slight nod to Solumedrol in this situation. Due to mass use and indication utilization. You've also got, and now this is a very close matchup. This is one that's a buzzer beater or, very high intensity game, both sides playing really well. But in this situation, I think that you have to, in terms of just overall utilization and some of the positive data with Solumedrol. And again, you've got some questionable data with hydrocortisone and certain indications that just makes it slightly edged out by Solu-Medrol here in a close battle.
Well, the methylpred is just, when you think of both, that kind of autoimmune type of route, hemonc, but then also respiratory. It's kind of the corticosteroid of choice when you're treating most of those things. And just by the sheer number of indications, I think that, although it's close, I think that's definitely the winner. I think spot on analysis there. Now the IV fluids battle it out in the next matchup as the 6th seed lactated ringers, or LR, takes on the 11th ranked albumin.
This is another one, a solid. LR is basically, when it comes to your fluids, a very solid team. They're going to be like your furosemide. They're going to play tried and true. They're going to have the same matchup. A lot of emerging data on balanced crystalloids right now, and sort of a hot topic on what they're doing. They're the team that's coming in playing really, really well at the right time that you don't want to play. So they're a 6th seed, but really could be more of a 2-3 seed when you look at all the data that's coming in. So, as we continue to find out, balance is probably best. Extremes in medicine is not going to be best for anyone. And then when you look at albumin, while it may have a role in a certain niche population, overall, when you look at utility in patient populations, cost, mortality benefits, I think you got to give the edge to LR here. And I don't think it's as close as the experts would think. I think you're looking at a 20-point game right here in favor of LR.
I think pharmacists everywhere had this pick. They're cheering you, but I can probably say with some degree of certainty that if this was televised on CBS like the normal Selection Sunday, I think some cardiothoracic surgeons would definitely be chirping your mentions in this albumin versus LR battle.
I agree. Listen, I understand, but again, you're talking niche population versus overall utilization. So, just because we rain on your parade doesn't mean it doesn't go on. So got to go with LR in this situation.
Now, what a fantastic matchup here. We have the Cerebral Edema Classic, the 7th seed hypertonic saline taking on the 10th seed mannitol.
Again, you had a great neuro matchup. Definitely one that you look forward to at the schedule when it's released on Selection Sunday. Just knowing that you're going to watch a good game. This is the type of game, Nick, whenever I'm betting, I don't bet because this could go either way, depending on the institution you're at, the training you had. But
you just want to love the game too. You just want it to be.
You just
got to
love the game, and you don't want to put money down because you just want to enjoy it. But in this situation, when it comes down to it, indication and overall administration, adverse effects, all of that, got to give it to hypertonic saline here. It's actually just had some newer data come out with heart failure exacerbations with diuretic resistant heart failure. So you got to give it to that slight niche. Again, I would be wary of betting on something like this, but watching it just for the pure excitement of the game, this would be a close one, real close. I'm talking 1-2 point match here.
Completely agree. You could have told me it was a 10 to 15 point win, and I would have believed you too. I think my bias for hypertonic saline, I think is would come out, but I am strongly on board with the 7 seed moving on. Now everyone's upset matchup is coming up next, the 5-12, right? You always look at those in your bracket, try to figure out, well, I can't have every 5 seed winning. It just doesn't happen. So here we have the 5 seed albuterol versus the 12 seed ondansetron.
So this is the one that you go into Vegas and this is your money making game, right? So you just said it, 5 versus 12. Not all 5s are going to win, and you gotta find the 5 that's going to be upset, and you got to put all the money on the 12. And this is again where you're going to make dinner that night. You're going to put in, and this is one you put the money down and say, boys, drinks are on me. So 5 versus 12, albuterol versus ondansetron. if you put money on ondansetron, you lost big. This is one. This is another, when you look at utilization and you look at ability to use other meds, right? So we've got Reglan sitting there. That didn't make the tournament. It's in the NIT as well, performing well. You look at overall just utilization. You've got something that's treating a symptom or treating an adverse outcome, so the patient being nauseous or vomiting, whereas albuterol is helping prevent some nastier symptoms later on. So you definitely lost big if you put money on Zofran on this one. So albuterol all the way.
That was like the popular public pick, whereas all the experts and all the sharps, is what they call really good gamblers in Vegas, they all had the money on albuterol. Yeah, you got to breathe, right? You got to be able to breathe. And so it
you know how they say you can't live without love? Living without oxygen is worse. So
that's exactly right. So that makes sense. Now, these next three matchups we'll move through just a little bit quicker for time, but Brian, definitely sure. We can go as deep as you would like in some of this analysis. So we have the 1 seed, the region powerhouse, regular insulin, taking on the 17 seed sodium bicarb.
Yeah, this Cinderella story for the bicarb stops here. So we're going regular insulin. Utilization, it's your Duke matchup, right? So it's coming in. You know they're gonna make it at least pretty far into the tournament. They're very rarely going to lose to that Cinderella. So regular insulin over bicarb here.
Yeah, it seems like one of those easy wire-to-wire wins where they're up 15, like 4 minutes in, and they just cruise.
This is the type
there.
of bet. Yeah, this is the bet that you get to make more money to bet more later.
And then you have the number 2 ranked levetiracetam facing off against the 15 seed potassium.
Yeah, so this is another one in terms of Cinderella story. You think they may potentially have a shot, but it looks like the magic has run out. The slipper no longer fits, and so we're going with levetiracetam.
And then the last game of the region, we have the pro-coagulant battle featuring 4-factor PCC Kcentra, the 4 seed, matched up against the 13 seed phytonadione.
All right, so here we've got a matchup of a team. So your phytonadione or your vitamin K is basically your slower team that can play defense and is big up front. But in the tournament, the NCAA tournament, you got to work fast and you got to play fast and you got to score fast. And that's Kcentra. That's your 4 seed. This is your Kcentra is kind of like your Florida State. They play really good offense and they're really fast out of the gate. So we're going with Kcentra in this situation.
Yeah, for use in critical care, which is what this bracket is looking for, that was a one-sided matchup, absolutely. So kind of summarizing that first round, so the round of 32 features mainly chalk. The higher seeds won every matchup except the absolute bracket-busting 14 seed DDAVP desmopressin beating furosemide, one of the I think they were one of the favorites of the people before this started.
So DDAVP was the team that the little engine that if you were a fan of them from that hometown, you put all your money on that, and you're looking at putting some hurting on some others as you move forward. And you're right. There's a lot of brackets that are upset, and that's kind of what March Madness is all about. The rest of the seeds winning, not always typical. You do see some more matchups, but usually you can see some of those regional matchups have 1 or 2, not just all from one. So I tried to keep it as consistent with some of our powerhouses, with the one occasional upset in there. So I think that it's exciting. You definitely could have gone either way in that situation, but I think with some of the emerging DDAVP data that it looks pretty promising.
No arguments from me. And the second round, starting off with a great classic neuro matchup. We have the 2 seed levetiracetam facing the 7 seed hypertonic saline. It's seizure management versus ICP cerebral edema management. All right, who's the winner?
All right. Thought long and hard on this as well. Just considering that we had the ESET trial come out, and you've got Keppra that's at 60 mg per kg, only stopping seizures for status at 50% of the time. I got to go with hypertonic here in that you've got a little bit better management of ICPs with it. I know they're a little bit hard to judge overall, but when you're only working about 50% of the time, I got to go with my tried and true hypertonic here.
Oh, baby. The 2 seed goes down. Woo. The underdog kind of beats the favorite here. I mean, you said it. You can give it multiple different ways, although the more data coming out with Keppra that you can kind of do that as well. But I guess if that hypertonic saline works, we won't need anything for seizure management, right? That'd be the ultimate goal. And you're right, it kind of be used in other scenarios. So definitely an upset, but when the analysts come on, they're not completely shocked. They're going to try to make you convinced that they knew it was going to happen, right?
This is a trap game, as they call in the bracket. So this is definitely one that on paper Keppra should win 9 times out of 10. But in the tournament, you only need, as Dickie B would say, you only need one shot, baby. So
now the next game, it's the classic fluid retention versus fluid resuscitation. Our Cinderella, the 14 seed DDAVP, going against the 6 seed lactated ringers.
Yes, another tough matchup. And this is one that if you're LR and you see DDAVP upset furosemide, you get worried. As a bettor, this is one that you get worried as well. Do I continue going with DDAVP and do I make money? Do I risk it? Or do I go with the tried and true? I think in this situation, while Cinderella is hot, if you look, they very rarely make it past that first or second round with if they get the one win at the very beginning. So I'm gonna stay consistent here with the rest of the brackets or previous brackets in years. LR nudges them out. It starts out very close. First half, you got DDAVP up by 5, and then LR comes out, settles down, wins it in the second.
You know, the run had to end sometime. It was fun while it was lasted, but that's exactly right. You know, Cinderellas typically don't make it through the first weekend, and they did not here as well. Now, the number 1 seed, regular insulin, taking on the number 8 seed, methylprednisolone. Ironically, this 1 seed is commonly used to treat one of the adverse effects from the 8 seed. It's funny how that worked.
Absolutely. So this is, again, you got your Duke. They're in the team of 30 or field of 32 here. Do they make it to the Sweet 16? And this is, again, you can always bet on Duke making it to at least the Sweet 16 there. And just like in this situation, regular insulin proves to be too much for Solumedrol. It's not even close. You treat the adverse effect, as you said, some hyperglycemia from Solumedrol. Definitely not making it. Solumedrol is definitely not making it. So regular insulin takes them down by like 20.
Yeah, seems like an easy choice here. You know, while your comparison of regular insulin to Duke is pretty good, I tried to do a comparison that might hit home for you a little bit, and I kind of feel like regular insulin might be Kansas a little bit.
Yeah.
You know, they've been around. They've been around for a while. They're always pretty good. They're kind of hanging in there, but it always seems like they just get brutal tournament draws and really tough matchups, and we'll get into that a little bit. But that's why. And I don't hate regular insulin or really dislike them. So I think maybe that's why. So maybe that's why you have different feelings, because you also don't dislike them. So you wouldn't make them Kansas either.
Yeah. I know I'll catch some flack for using Duke instead of like North Carolina or Kansas, like you said. And but for every North Carolina fan out there getting upset that I'm saying Duke, you guys stunk this year. Just admit it and move on.
No, the season. No, what they're going to say is, no, that season didn't finish. We were coming in hot. We were going to be the 9th seed, and we were going to start cruising. Like, that's what they could say now. That's what any of those teams at the end can say. Now, wrapping up the round of 32, we got the 4 seed Kcentra matched up against the 5 seed albuterol. Kind of like you've talked about in previous matchups, both vital, but in obviously extremely different ways.
Absolutely. Now this is a very, very tough matchup, and this is another game again that it's a trap game. You don't want to bet it. This is not one that you have to be willing to lose money, because this could go. This is a coin flip in this situation. Very tough matchup. Just one that you want to watch to enjoy the game. Now, like you said, albuterol, in terms of breathing, in terms of its abilities, has shown time and time again. We use it in every patient population pretty much, and it's definitely needed. It's needed now more than ever, especially with the COVID situation. And looking at that, Kcentra's got more emerging data on its utilization, and not just warfarin reversal, but you've got it with DOAC reversal. There's some data for its use in trauma coagulopathy. There's data for its utilization in liver failure. And so, don't just limit Kcentra to your warfarin populations. There's some people that would do that. And so I think, though, that with the emerging data and some of the cost-effective strategies that Kcentra has, I'm going to go ahead and give the slight nod to Kcentra, but this one goes into double overtime.
Yeah, the most fun game of the region so far has to be this one. And I think what kind of just nudges it a little bit differently is it's the critical care, right? Where you're and although yes, albuterol is going to help you when you're breathing, those patients are also getting intubated and things. Whereas when you're bleeding, right, or you have coagulopathy for one reason or another, that's going to start working now, while the other interventions may take a little bit of time.
Exactly. And with some of the cost-effective strategies that's out there now, it's not going to break the bank like it was 7-8 years ago. So I really think that it's got some strong emerging data too. And so you can't just limit it to warfarin at this point. So definitely a close matchup, and definitely one that was I took a lot of time thinking about, but agree, when you're talking about the final step being either I'm bleeding into my brain or albuterol's trying to help me prevent getting intubated. I think that brain bleed for me, just being the neuro guy, I'm going to go with Kcentra.
This Potpourri region, the Sweet 16, it's a good mix of kind of the more of the favorites and some upsets. Regular insulin and Kcentra, both top 4 of the region, as well as then LR and hypertonic saline. Those are the 4 that are advancing. And the first matchup is the battle of the fluids, the 6 seed lactated ringers taking on the 7 seed hypertonic saline.
Right, and so I think I agree with you here. We've got a good mix of teams that we thought should be here, and teams in meds that maybe were a little bit of a Cinderella story, being a 6 seed and 7 seed. Try to evenly distribute that here. So LR versus hypertonic, again, if you start looking at the criteria for utilization, hypertonic probably going to be in a lower percentage of populations that you're going to use. LR, for the most part, is going to be widely utilized, maybe not in your trauma population. But other than that, it's going to be something that you can utilize quite often, and some good data, some decent data on mortality for balanced crystalloids. So I think in this situation, if you're looking at this, I think you got to give the nod to LR. I think that it's one that you can't argue with the utilization of balanced crystalloids and some of the mortality data. And I think that hypertonic just has such a small niche overall in critical care compared to LR that you got to give it. And then in terms of cost, they're both pretty cost effective.
Yeah, tough choice, but no argument here. I think the single biggest argument is just the amount of patients who can use one versus the other, and that kind of tips the scales a little bit.
Right.
And then I think what we have to say up to this point, probably the most heavily anticipated matchup, number 1 regular insulin versus number 4 Kcentra.
You've got Duke versus Florida State right now. This is the way I look at it. I honestly think you look at it this way. Kcentra's got some emerging data. They're not the team that you normally would have thought would have been here, probably. You knew they were going to make a run. You didn't know how deep they would make a run. And then regular insulin, they've been here before. They're supposed to be here. This is one that's tried and true. And you look at the potential for upset. And historically, if you look at the data, 75% of the time, the number one seed makes the final Elite Eight and Final Four. But being a Florida State guy, being a K-Centra guy, being a neuro guy, all the emerging data, I'm giving it to K-Centra. The upset alert, baby. Number 4 seed over number 1. And I saw some of the pre-bracket recordings on this utilization. And I know that this will be a pretty controversial pick, but listen, I'll go to bat for K-Centra any day.
I think people are going to feel strongly in favor and strongly against. There's going to be really nobody that's kind of indifferent to it. Yeah.
There's not a neutral stance on that. There's no, okay. There's going to be one way or another for sure. I definitely hear that.
Now, our Elite Eight, the showdown, old school versus new school. It's kind of the 6 seed LR versus the 4 seed K-Centra. So who's gonna cut down the nets?
Man, this was another one. Looking through it, part of me was like, why did I put myself in this position and having to decide on that? So I tried to reflect on this for a couple of days, really, and just take a step back, try to breathe for a second, and understand that these matchups are going to be amazing. But in this situation, again, when you talk about critical illness and the need for K-Centra versus the need for LR, is the data for LR that compelling over normal saline? It depends on who you talk to, but I could probably get by with a little normal saline in my life, or even a touch of albumin, depending on who you're talking about. Whereas when it comes to reversal of coagulopathy, I need that K-Centra right now. So K-Centra is going to the Final Four, baby.
Boom. The champion, the 4 seed K-Centra. Now hear me out for a little bit. You have K-Centra as being Florida State, and I tried to kind of create good comparisons, and I kind of thought that K-Centra was like Virginia, and kind of like Virginia in this sense, because I think about 18 months, maybe 2 years ago, when we heard there was a 10A antidote coming, that Indexa was coming, it was like, well, that's about to be the nail in the coffin. Like, there's going to be an antidote. We're not going to be using PCCs. It's kind of like when UVA was the 1 seed, and they were the first 1 seed to lose to the 16 seed, kind of UMBC. You know, they thought that it was over. And then what happened, right? UVA came back last year and then won the title. And now, right, you look, you know, K-Centra still has widespread use, even with Indexin Alpha, which we know we're not going to get into that, but it's like it's kind of the comeback story here in a sense, when we all kind of thought it was going to be kind of dead in the water.
Yeah, I agree with you, and to be fair, if you had something better than K-Centra, I'd use it. But in this situation, and that's my slight nod and slight nudge at the drug that we won't name, but yeah, I mean, in this situation, you have the potential for widespread use if used appropriately in a cost-effective manner. It's definitely something that every critical care pharmacist and ED pharmacist want to be able to get their hands on right away.
Completely agree. All right, so out of the Potpourri region, the 4 seed K-Centra advances. Now, Brian, hang tight. We're going to take a quick break. You know, obviously, we're going to have you back to talk about the Final Four matchups. Now, if you play roulette, for example, do you prefer putting money on red or black, or do you kind of go with whatever is suiting you at that moment?
Put it on black and let it ride, baby.
Oh, go put some money on black, and we'll come back to you soon. Okay.
All righty, sounds good, bud.
And we have reached the final region of the critical care medication March Madness bracket, and our official bracketologist for the pain, agitation, and delirium, or PAD region, is Melanie Smith. Last but certainly not least in our analysis by any means. Now, Dr. Melanie Smith is a graduate of the University of Arkansas for Medical Sciences. She completed her PGY1 residency at University of Florida Health Jacksonville, and she completed a PGY2 critical care residency at the Medical University of South Carolina in Charleston, South Carolina. And she's been practicing as a clinical pharmacy specialist in the surgery, trauma, and burn ICU there for 3 years. Melanie, so glad you were able to join me today. How are you?
I'm great. Thanks so much for having me today.
Absolutely. Now, we're talking college basketball here. So, who is your favorite college basketball team? Because you've, just from your intro, you've certainly lived in a lot of SEC cities.
Yes, I'm an SEC pro now, but my favorite team for sure has to go back to home to my Arkansas Razorbacks. We don't have a professional team in Arkansas, so almost every Arkansan is a crazy, hog wild Razorback fan.
Now let's kind of talk about that 1994 title, because that's, when I think of University of Arkansas, that's the first thing that I think of. What do you remember about that team?
Well, as you can imagine, that was kind of a huge deal for the people in Arkansas. I was in, I think, junior high when that game went on. And I still remember it in very vivid detail, exactly where I was sitting on the couch at my parents' house watching all of that game. Back then, Arkansas was known, as Coach Nolan Richardson called it, 40 minutes of hell. So those games were really fast-paced. They were exciting to watch. We were a first seed that year, and we were playing Duke in the finals. So as you can imagine, everyone except for the Duke fans probably wanted to see them go down.
Everybody.
We played them pretty close. I don't remember exactly what the score was, but it was really close, back and forth game until half. And then early in the second half, Duke came out to an early lead. They got 10 or 12 points ahead of us. But then we started to kind of close the gap. And I still remember one of our best shooters was Scotty Thurman. He hit a big, huge three-pointer in the last few seconds of the game that kind of brought us closer. And then we ended up going on to win by 4 points. And that was Duke's hope for a three-peat for a national championship, but we were able to dash those hopes by winning our first national championship. Now, my favorite... Oh, go ahead.
No, I was just going to say, all us non-Duke fans are standing up, giving you all a round of applause for stopping the three-peat.
For sure. One other funny thing about that year was my favorite player was Corliss Williamson. And his nickname, he actually went on to play in the NBA, but his nickname was Big Nasty. And that's because he was a big forward. He was awesome in the paint. He played nasty, as they called it. And I actually chose his number in junior high because of that. So I was number 34 in junior high, which is really funny. I wasn't great at basketball. And I was not very big. My basketball skills were far from nasty. But that is definitely one thing I remember about that team.
Now, you work in a surgery, trauma, and burn ICU, so just holding your own in that environment, I have a feeling that you could probably be pretty intimidating.
If you ask some of my surgery residents, I think they would agree with that statement.
And then, not only did they win the title in 1994, but then the next year they even made it back to the title game. So I can understand why those teams kind of live on forever in Arkansas lore.
For sure. We're hoping to one day get back to that glory.
Now, the Big Nasty, that's just such an awesome nickname and describes 90s basketball perfectly. Like, a lot of elbows, a lot of blood, a lot of just posting up and guys standing around. Kind of like your description almost sounds like the most appropriate nickname for kind of the COVID-19 coronavirus, right? The Big Nasty, or at least maybe the most work appropriate nickname that kind of comes to mind about this virus that everyone's dealing with right now.
I totally agree. I don't think I could think of a better nickname for this nasty bug out there wreaking havoc all over the world.
So MUSC is located in Charleston, South Carolina. Now, I've actually never visited Charleston, but even I know that brunch and Charleston kind of go together like peas and carrots. So when our social distancing is over and we can safely leave the house, what's one of your go-to spots when you're looking for some delicious brunch around the city?
I debated about telling you my true answer because Charleston, when we're not social distancing is sort of overrun by tourists. But one of the places that tourists and locals alike cannot get enough of is Hall's Chop House. So Hall's Chop House is actually one of the best steakhouses in the country. They are known for having delicious steaks, amazing appetizers and sides that go with these perfectly cooked, thick and juicy steaks. But they're also known for just having great hospitality, showing off that true Southern hospitality and treating every customer like they're one of the family. So it's the Hall's family that owns this steakhouse. But I think one of the coolest things that they do is called a gospel brunch. So on Sundays, either before or after church, or you get enough gospel singing, you could probably count this as church, but they will have gospel singers sitting down there playing the piano and other instruments and singing gospel songs while you're having your mimosa or your Bloody Mary with your delicious brunch. So the food's delicious, the atmosphere is awesome. They treat every customer just like their family. It's definitely one of my favorite places in Charleston.
Yeah, that sounds like an absolute blast when you have not only one of your favorite restaurants or places to go in general, but then when they add like a show or like something along with it, that sounds like it's unbeatable. As long as you probably can avoid that 60 or 90 minute wait, that's probably pretty common there.
Yes, it is for sure. But the shrimp and grits there are worth every minute of that 60-minute wait for sure.
Now, we're in a semi-quarantine state right now. Everyone is appropriately trying to stay at home, and so just for some of the listeners out there, maybe if they're struggling for something to watch, is there something that you're streaming right now that you would recommend to the listeners?
Yeah, for sure. Now, this has to be a no judgment zone because I want to preface this recommendation with, I work really hard during the day. I'm using my brain to think all the time. So I really enjoy mindless reality TV, something that I don't really have to think about and I can just laugh at how silly the people are.
Before you tell us, so we're in the trust tree. We've already established this, so that is a no. This is a no-fly zone for criticism. So awesome. Honesty is key. Absolutely.
So one of the things that I recently finished was Love is Blind on Netflix.
I knew it.
You've probably heard that. I found that to be one of the most disturbing things I've ever watched, as far as getting engaged to someone in 5 days that you have actually never seen their face before. But it kind of turned into one of those things that was like a train wreck that you just couldn't look away from. I could not put down the remote. I think I watched the whole season in like 2 days. So that's definitely a good one. And then my other one that's a little less mindless that I think is awesome, especially for pharmacists, was another Netflix special that was called The Pharmacist. And I think that one fits in so good with this region because it was about a pharmacist who lost a son to opioid addiction. And after that, he kind of single-handedly took on the opioid epidemic in his like rural Louisiana town. And even went so far as to helping take down some pill mill physicians that were contributing to the opioid epidemic, and even contacting Congress about Purdue Pharmaceuticals, who were the makers of OxyContin. So I found that to be, this amazing story about this vigilante pharmacist that really went above and beyond to try and take care of his community.
Yeah, that's on my list. Whenever you see a positive portrayal, so positive like that of pharmacists going above and beyond, you gotta support it and you gotta watch things like that. Great recs all around. Because sometimes mindless is nice. Mindless is nice sometimes.
Totally agree.
So kind of diving into the PAD region. So the top 4 seeds in order are propofol, dexmedetomidine, fentanyl, and ketamine. So how do you feel about those? Are they okay? Would you do some reseeding? What do you think?
Overall, I think the top 4 seeds are pretty good. Honestly, I was a little bit surprised to see ketamine up there. Even though I love ketamine, I think it's often forgotten as a PAD kind of heavy hitter. It's definitely gaining some notoriety as an agent that can play with your big guns like propofol and dexmedetomidine. So I was definitely happy with the overall top 4.
Yeah, when we did the Democratic vote, every single person voted for it every single time. It was never voted to be cut. So I think that the other experts in the bracketology panel agree with you.
I would for sure say that. I think a lot of that too is because we're pharmacists. I find myself bringing it up to my doctors a lot more rather than them asking for it. So I think pharmacists are really more hyper aware of what an awesome drug it is and are starting to be the ones that are kind of pushing more for it.
Now, did you feel like any medications got snubbed or any kind of you felt belonged in this region but weren't here?
There were a couple. I would have liked to see some more oral agents. Just because we have ICU patients doesn't mean we can't use intraoral routes. So one that stands out to me as a snub was clonidine. I think it's a really well-rounded player. It really helps save costs when you're talking about weaning off IV agents, whether that be Precedex or even using it to help wean other IV agents. And, that cost savings is something that every pharmacist can really appreciate. A couple others I would have really liked to see the cut would be maybe another multimodal pain agent, perhaps an NSAID or a muscle relaxer like methocarbamol. Those are definitely 2 drugs that I'm reaching for pretty often when it's coming and working with my trauma patient population. So I would have liked to see those on there as well.
Yeah, to me, there were 2 that stood out. You mentioned the NSAID, and yeah, ketorolac was something that stood out to me that I thought I probably would have put there. Then the other one was methadone. With kind of its multimodal kind of analgesia, opioid. It can do kind of a lot of things. So those were 2 that stood out. But I agree, the IV to PO, I think we can very easily get stuck on the IV route, and that kind of showed with this bracket or this region.
Yeah, we were very IV heavy in this bracket for sure.
Now, no play-in games for this region, so we can start with some fantastic first-round matchups here. And your region certainly has a few. So we kick off the analysis with this delirium heavyweight bout, the 5-seed haloperidol taking on the 12-seed quetiapine. Definitely a classic 5-12 barn burner here.
I think this one's definitely going to be a close one. It's one of the toughest matchups in the bracket. Haldol definitely plays a tough game. It's a nursing crowd favorite due to them being able to give it really quickly. They can give it IV or IM in those patients that are really wilding out. But I think quetiapine's going to pull through on this one. So kind of what led me to choose quetiapine is the patient population that I really like to use it in. As we know from the 2018 PAD-IS guidelines, using antipsychotics to treat hypoactive delirium is no longer recommended. And definitely from the Mind USA trial, using Haldol to treat this patient population with predominantly hypoactive delirium didn't really show any improved outcomes. It didn't shorten their duration of delirium compared to placebo. So for that reason, I think people have started to get away from the routine use of haloperidol. So I'm starting to see quetiapine use still, and I think that's due more to its sedating effects than Haldol. So in my ICU, we use it frequently to treat those very agitated delirium patients to help provide some of that sedative effect. And then we're also using it occasionally in those patients that are requiring very high doses of sedatives. So if they're on very high doses of propofol and still not maintaining adequate sedation that we need, then we may initiate an agent like quetiapine to help improve that sedation profile there. So some of this choice is really due to guideline recommendations, but there's definitely a lot of personal experience bias there.
Yeah, I completely support this outcome. I definitely try to use Seroquel when possible. I think the only downfall is, right, there's no parenteral option. But there are other potential agents that we can use that we'll get to. I see this 512 upset's a popular pick, so I don't necessarily see this as shocking as it would be. I think this is probably one that a lot of people had filled out as a guess, this 12 seed kind of coming through.
Yeah, I definitely agree. Like you mentioned, the lack of an IV option kind of makes it a little bit harder to choose your Seroquel, but I just think the profile of the patients that we're trying to treat with these antipsychotics definitely favor using that more sedative agent.
Yeah, 100%. So moving kind of to the pain management matchup, we have the 6 seed oxycodone versus the number 11 acetaminophen. It's kind of the opioid versus the OTC.
Yeah, I think we have a bit of a Cinderella story on our hands with the acetaminophen here. So in the past, I think it's been kind of underutilized and not really respected for the true contender that it is. But, like I mentioned with the pharmacist and the Netflix show, we're in a day and age where we're constantly combating an opioid epidemic, and more people are starting to recommend reaching for those non-opioid pain relievers and using a multimodal approach. So, for me, acetaminophen wins this every time. It's been shown to reduce, perioperative pain and opioid requirements for patients. And it's also gotten a direct endorsement from the new 2018 PADIS guidelines. So I think we're going to see Tylenol going deep in this tournament.
Yeah, acetaminophen is a huge sleeper here because, like you said, not only does it work for pain, reducing opioid requirements, but also fever reduction here in multiple routes of administration. I completely agree. I think the slippers are going on there. Back-to-back upsets. What a way to start it off. So we'll kind of shift gears here, focusing on the 7-10 matchup, the battle of the paralytics. Number 7, succinylcholine versus number 10, rocuronium.
So for this one, I'm just going to say this is a pure personal preference. And if I were a different type of ICU pharmacist, I would have probably chosen something different. So I'm going to go with succinylcholine here. If I were a MICU pharmacist, I probably would have chosen rock. Due to that kind of theoretical concern of hyperkalemia with succinylcholine and the patient population you see, in a MICU, your end-stage renal disease, patients with multiple comorbidities, that kind of thing. But I take care of all the traumatic brain injuries in my hospital, and a neuro exam is probably one of the most important things for those patients. So I like my neuromuscular blockers to wear off fast. Succinylcholine does just that. You got a time for it to be worn off of about 4 to 6 minutes compared to at least 30 minutes with rocuronium. So that's buying me a lot more time to be able to get neuro exams, especially early on when they just got there. So that's kind of why I decided to go with Sux in this matchup.
I could feel the love that you had for Sux right there. And the funny thing is, you said if you worked in like a medical ICU, you'd feel different. Like I practiced previously in like a mixed kind of med surge, and that's exactly right. I was like, well, you could argue either way. I'd probably say I'm more of a rock guy with some of those things, and you hit everything I was going to say with a nail on the head. I think this is one though where like, just because you anecdotally feel strongly one way, there's not a lot of evidence to say you're wrong by any means on that. I don't think you're taking a hard line to some crazy stance or anything like that.
Definitely not. I kind of looked in to see if there was any comparative data between the two and didn't really find anything out there.
Now, the 8-9 matchup, although we may not love benzodiazepines, there's sometimes a necessary evil. We have the 8-seed lorazepam battling the 9-seed midazolam, kind of the benzo battle here.
Yeah, I think this one, again, is going to come down to kinetics for me, just like the previous matchup with the Sux versus the Rock. And I think lorazepam's going to barely squeak by past the midazolam here. For me, midazolam is a little bit favorable with the shorter half-life. So, 2 hours versus about 14 hours with the lorazepam. But what it comes down to is the way that it's metabolized. I end up seeing a lot of patients with, both liver and renal dysfunction. And so the metabolism of lorazepam, goes to an inactive metabolite, which isn't going to hang around as long as the Versed or your midazolam is getting metabolized to an active metabolite in the liver, which is renally excreted. So your patients with both of those end organ dysfunctions, it's really a double whammy. So for me, as much as I hate benzos, period, if I had to choose one, I would choose lorazepam.
And that would be, the patient group that you're more likely to kind of use that agent in. I agree if you're doing, the ICP status epilepticus kind of refractory management and you're doing these massive doses, right? I think some of the side effects from lorazepam, like the osmolar gap and thing, might come to get you. But that is a niche population. I think when you're talking more general ICU use and applicability to everybody, I think in the end of the day, that lorazepam is the better choice of the two evils.
Yeah, I totally agree. You're right. I didn't mention that about the osmolar gap and the diluent that you have dissolved all of your lorazepam in that causes that metabolic acidosis. But that's definitely something to consider. But for me, we're not using a drip that often, so I'm gonna stick with the shorter acting lorazepam and just the PRN doses for that.
No, and the role of the bracketologist is not to discredit the team you picked, right? You can only say positive, glowing, amazing things about your team, right?
You're right. I'll try to stick with that. Yeah. I retract my statement that I hate all benzos.
Now we'll move a little quicker through the rest of the first round as it looks like the top 4 seeds have pretty easy matchups, but definitely go into as much detail as you'd like here because we have the 1 seed propofol taking on the 16 seed phenobarbital.
Yeah, I think we're going to start seeing a lot more phenobarb in the next few years as more and more people have an interest in using it for your kind of refractory alcohol withdrawal. But unfortunately, I think propofol is just a sure bet to move to the Sweet 16 at least.
It feels like phenobarb here is kind of like the mid-major everyone loves. They hit the buzzer beater to make the tournament. And they kind of feel like, I don't know if you saw the video a couple weeks back of he was the student manager for Jackson State. His name was Snacks, and he drained a 3-pointer like 8 feet behind the line. It feels like phenobarb is kind of like Jackson State and Snacks, or it's like the internet and like the Twitter followers, when we announced this, phenobarb was probably the number 1 drug that people chimed in talking about. They loved it. So I feel like it's the mid-major that they love because once you get out of severe alcohol withdrawal, comparing that to propofol, it's gets a little tough, gets a little dicey there.
Right. Yeah, that's kind of what I was thinking with this one. If I'm trying to apply this to a broad patient population, which one's going to be my workhorse? Definitely not going to be sedating every ICU patient with phenobarb. So to me, like you mentioned, phenobarb, that mid-major, they're exciting, they're fun, they're kind of new to the tournament, so everybody's rooting for them at first, but when you line them up against a Duke or a Kentucky or a UNC, those are your propofols right there. Yeah. You're not going to beat those.
Now the next matchup, it's number 2 ranked dexmedetomidine versus cisatracurium, the 15 seed.
So for me, we had the publication of the Rose trial in this past year. So I think we're going to start seeing cisatracurium fall out of favor because of that. I would have liked to see cisatracurium ranked where it didn't have to go against Precedex, and it might have made it out of the first round. But for me, I'm not surprised by an easy victory by Precedex here.
Yeah, until the release of the Rose trial, not only would Nimbex be ranked higher, but it would definitely have some, you would be able to argue a couple wins there. But yeah, ever since that, I mean, it's kind of really hard to argue its use. And as somebody who I was on the side of the fence where it's like you needed to do full dose, all those things. It was kind of a blow to the ego when when the results of that came out.
It definitely was. I really not that I enjoyed paralyzing my patients, but I was kind of a purist in how we used it and wanted to make sure, we were doing it exactly like the previous trials have been done with the Curasis. And But, with Roe's trial coming out, it's kind of hard to say that it's any better than just doing the appropriate amount of sedation.
Mm-hmm. Yeah, that was a tough, you know what? We lost the battle, not the war, though. That's what it is.
I agree.
So the next game we have fentanyl, the 3 seed, playing the 14 seed dextrose.
For me, fentanyl's a workhorse in the ICU. Although we are always trying to think of ways to reduce our opioids, fentanyl is really the ideal opioid. Quick acting. It's going to adequately treat pain. It's not too long acting, so it's not going to interrupt your neuro exam if you're using it PRN anyways. So for me, you got to go with fentanyl over dextrose here. I'm really not at all surprised by this being the victor in this matchup.
Yeah, that was a wire-to-wire win. No, never in doubt. And then wrapping up the region here, the 4th-ranked ketamine matched up against the number 13 seed gabapentin.
Yeah, I think this match is a close one. So first of all, I kind of think gabapentin got robbed in being seated this low. I wanted to point out that gabapentin, just all neuropathic pain meds in general, were one of only 2 strong recommendations in the entire most recent PADIS guidelines. So I think gabapentin got robbed by being, matched up with ketamine this early on. I think it would have made it 1 or 2 more rounds if it hadn't been matched up against ketamine. Ketamine is just hot this year. There are so many new publications coming out. I actually did a PubMed search to just see kind of what was out there, and it showed over 400 published articles about ketamine related to the treatment of pain just in this past year. Everyone, like I mentioned before, especially pharmacists, I think, are starting to get on the ketamine train. It just has so many different uses, especially those related to treating pain and agitation.
Yeah, it's just a nice option to kind of have in the back pocket when things are kind of, you can't really figure out what to do. Sometimes that can be something to recommend and really kind of make a lot of things better.
Definitely agree.
When I heard you say that they're so hot, I instantly thought of Zoolander when I forget Will Ferrell's character's name. I think it was Mugatu. It's like, he's so hot right now. That's all I could when you said that. That's instantly that's all I could think of. I'm not sure if you did a great impression or what there, but ooh, all right, tangent over. So this region is certainly on its way to busting some brackets because the top 4 seeds all advanced, but Seroquel and Tylenol pulling off some upsets here and making their way into the round of 32. And the fun kind of keeps... Oh, go ahead.
Oh, no, go ahead. I was just going to say, I definitely think that the Seroquel and the acetaminophen are going to be some Cinderellas all the way towards the end.
And so we're gonna start with one of those right now. We have the as you described it, the workhorse, the number 3 fentanyl versus our Cinderella, the 11 seed acetaminophen.
Yeah, so I could say a lot of the same things that I said, would Tylenol beat out oxycodone. You have your fentanyl, which, like I said, it's a workhorse. It is an early favorite for ICU care. It has excellent kinetics as far as an opioid goes. But I'm going to say that the sleeper, number 11, is going to beat out our fentanyl. So Tylenol for the win here. Same reasons that I said with Oxy. It's becoming a drug that people are reaching to help minimize your opioid exposure in these patients. It's well-rounded in that it treats fever. It also treats pain. And there's really not a lot of bad side effects to using acetaminophen as compared to using your opioids.
So I think the question here is fentanyl overrated, or is acetaminophen just the classic underdog or sleeper?
I think it's a little bit of both. I think acetaminophen is definitely underrated, and I think fentanyl is great if you use it appropriately, but it's definitely overrated if you're using very large doses or if you're putting people on fentanyl drips versus using PRN dosing and assessing pain appropriately.
I think the real question here is, would your ICU team be shocked by this pick here? Because I'm leaning towards probably no.
Oh, absolutely not. When I started in my ICU, everyone thought that if a patient was intubated, they had to have a fentanyl drip. And now if I come in the morning and a patient's on a fentanyl drip, they are running to me to explain why before I get mad about it. So it's no secret that we definitely use an opioid sparing regimen in my ICU.
Now that's a tough act to follow here, but we have the 4-seed ketamine taking on our 12-seed quetiapine. Is this going to be upset Cinderella number 2?
As much as I, was loving on quetiapine earlier, I definitely don't think it has what it takes to beat ketamine. So ketamine's going to go forward in this round for sure. Like I mentioned, we have kind of all different types of uses for ketamine. We'll really be able to use that in all different patient populations. So I think it's just more applicable to a broad ICU population than the quetiapine.
Yeah,
that's
a
tough
agree.
one though, man. That's got to be a close game.
That's the buzzer beater where
sure.
quetiapine thought they won, and then ketamine hit a 3 to end it, and everyone's going nuts on the court right now.
Yeah.
So the 1-seed propofol taking on the 8-seed lorazepam.
This was probably my easiest pick of the whole bracket. So propofol is going to cruise past lorazepam in this matchup, hands down. There is just an overwhelming amount of literature supporting non-benzodiazepine-based sedation regimens. You have the full support of the PADIS guidelines saying that your propofol and your Precedex are better than benzos. So hands down, you got your number 1 seed taking this one.
Yeah, no, absolutely. Cruised, obvious choice. I don't think anyone would have any argument here whatsoever.
For sure.
And kind of rounding out the second round, it's the 2-seed dexmedetomidine versus the 7th-ranked succinylcholine.
For me, this was a little bit of a tough matchup because, as I'm thinking about the drugs that I would want to have in my ICU, I definitely want to have a neuromuscular blocker there. But if I had to live without it, I guess I could in preference of using Precedex. So I'm going to go with this being a tough matchup, a close one, but Precedex is going to squeeze by for the victory in this one.
Yeah, Dex may sleeper kind of be the favorite of this region, and it's definitely in the words of Dickie V, the diaper dandy. For those less familiar, the diaper dandy is a term. I don't know if he still uses it or not, but Dick Vitale used to describe a great freshman player. And when you think about just relatively speaking, Dex is definitely a newer drug, definitely kind of in the freshman class of this region. So not surprising that it kind of made it through.
For sure. I like that reference. I hadn't thought about that. It's definitely a young player. And I think it's going to be around, we may even see a 5th-year senior out of Precedex one day.
Mm-hmm. Yeah, so the PAD Sweet 16, it's propofol, dexmedetomidine, ketamine, and acetaminophen. Ooh, those are some really great matchups. Definitely a combination of the higher seeds making it, but still having kind of at least 1 or 2 kind of upsets people maybe didn't think were going to be there.
Yeah, for sure. I'm excited to see what the rest of the Sweet 16 looks like as far as the winners go.
Now, the favorite. Well, what I declared the favorite, I'm not sure if that's how anyone else feels, but the 2-seed dexmedetomidine taking on our Cinderella, the sleeper, the 11-seed acetaminophen.
Yeah, so for me, this was a tough matchup because you have 2 teams that have a really totally different skill set. So ultimately, for me, acetaminophen is going to win. And that's just really due to its kind of applicability across all spectrums of all ICU patients. We have an IV version of acetaminophen, even if, no pharmacy managers want to let us use it. We have a PO version and even a per rectum version if we need it. So I think that's one of the great things about acetaminophen is its different routes of use. We can also use it through the course of kind of their whole ICU stay. And like I mentioned, it has very few side effects. It's got a great safety profile. You can use it for multiple indications, pain, fever. And then recently there was even that Dexaset trial that came out. That's a little bit of an interesting trial, but it did find a signal for a decrease in delirium when you added acetaminophen to a sedation regimen of either propofol or Precedex. So I thought that was an interesting finding as well, and maybe due to a better component of just controlling pain better. Not that I don't think that Precedex isn't a great drug. I just don't think it's as well-rounded as acetaminophen from both a safety and then a potential patient population standpoint.
We officially have our Cinderella. Wow.
We do.
And talk about a tough road to get to the Elite Eight. Acetaminophen beat oxycodone, fentanyl, and dexmedetomidine to make it here. I mean, that is a route.
Yeah. I don't think you could have a better Cinderella than that.
It kind of reminded me a couple years ago, reminds me of like the Loyola Chicago kind of team. And it was Sister Jean. Remember, she was the chaplain and also cheerleader. She was like the internet sensation of 2017. Yes, that's our team to relate acetaminophen to, right? Both a little seasoned. They've seen some things and now they're peaking at the right time.
I totally agree.
Now,
they hit March at their prime.
Yes. Now, not to be outdone, probably up to this point, the most anticipated matchup of the region, the 1 seed propofol versus the 4 seed ketamine. I mean, two just PAD workhorses, tons of indications, tons of different patients. Who ends up winning this?
Yeah. You know, I've been trying not to spill all my beans about ketamine as we talked about it through the bracket, because I think this is where I really want to draw the attention to how awesome ketamine is. So I think this is one of the most important matchups of the bracket so far. Propofol is definitely a workhorse in the ICU. You can use it for multiple things: RSI, sedation, status epilepticus, even severe refractory ethanol withdrawal. So I think it has a pretty decent kinetic profile. It's fast on, fast off, minimal concern for end organ dysfunction. But I think its weak spot and the place where ketamine's really going to attack is its effects on hemodynamics. So when you have a patient who is on, needs to be sedated and is on 2 or 3 pressors, you're probably not going to have that patient on propofol. So for that reason, I'm going to go with ketamine. So I think ketamine's gaining favor for a variety of reasons. The hemodynamics is definitely a big one. And I reach for ketamine a lot of times when we have a patient who's hemodynamically unstable and we still need some sort of sedative agent because it's so neutral as far as affecting your hemodynamics. I think it's one of the most well-rounded drugs in the ICU right now. You've got it working on all different things. So you can use it for RSI. We use it frequently for procedural sedation. It has low effects on delirium, which I think makes it attractive. You can use it for, treating pain at lower doses, use it at very high doses for status epilepticus or status asthmaticus. So I think just right there with all of its uses, it makes it one of the most favorable drugs in this whole bracket. Other great things about it, the different routes you can use. So IV, of course, use it IM in some of your really wild emergency medicine patients if you have to. It can be used inhalationally. And then one more, since I have recently become a burn ICU pharmacist and started taking care of those patients, is actually using it PO. So we are giving it PO to patients to help with burn procedures and help with wound care procedures. And it has a really great side effect profile when you're using it that way. And patients seem to really tolerate procedures a lot better with a lot less use of opioids and other sedative agents. So for me, ketamine's a shoo-in in this matchup.
Yeah, I think even as the 4 seed, I don't think as many people see this as an upset. Like, I feel like a lot of people, it's kind of 1A, 1B in a specific sense. And ketamine kind of feels like they have 4 starters who are seniors, and they've all been together for years. And so you're right. They're peaking at the right time. They got a lot of things going in their favor.
Yeah, definitely hitting its prime in 2019 and 2020. If you were at SCCM, I know you probably saw all of the different abstracts that were being presented about ketamine. And then one of the big STAR Research Award papers was all about using ketamine for sedation. So I think it's definitely hitting its prime.
Yeah, you are right there. You couldn't turn your head without seeing something for ketamine, whether it was a talk or research or something. And
for sure.
This is why you're the expert, because I looked at this region and thought that this was probably going to be propofol versus dexmedetomidine, maybe fentanyl here. But instead we have the 4-seed ketamine kind of taking on our Cinderella acetaminophen, the 11th ranked team in the region. So Melanie, who's cutting down the nets here?
It's going to be ketamine. If you can't tell by my huge plug for ketamine in the Sweet 16, I do love some Tylenol, but I think ketamine is just the most well-rounded drug in this region for sure.
Yeah, after some absolutely great games, the Final Four, the region winner, the 4th ranked ketamine, and ketamine's kind of the old dog learning tons of new tricks. It kind of feels like ketamine is like Villanova, because Villanova definitely had some success in the 80s. It's got some good appearances and a national title there, but it's come back in a big way right out of the last, won 2 titles in 3 years. And kind of the same with ketamine. It's an older drug that's now, it's got all the research. It's just you go to a conference, it's all you hear about. So very hot. So we got our Final Four team here, ketamine, and Melanie, hang tight. We'll come back to you in just a bit to kind of break down the Final Four.
All right, thanks.
Wow. Another really big thank you to Brian and Melanie, who certainly kept the fun rolling for us today. I really hope that everyone has been enjoying this as much as we have, myself and the other bracketologists. It's been great to inject a little fun into our normal kind of critical care and pharmacy discussion. So we've made it through our region analysis at this point. We've broken down all of the brackets and figured out who the Final Four teams are. And then tomorrow, listen to the finale where we kind of crown the champion. It's going to be part 3 of our 3-part episode breaking down the critical care medication March Madness bracket. And all 4 bracketologists are back tomorrow to help give their insight into the Final Four. So be sure to go to the official Twitter account. That's at PharmacyToDose, TO2Dose, to cast your vote in the listeners bracket. Every region is there, and there's Twitter polls to be able to help you all decide who you think is the best medication in critical care. And then don't forget, there's also a printable bracket available to be downloaded on the website. That's pharmacytodose.com is our website address. So a lot of fun. Be sure to tune in tomorrow. And then again, if you didn't listen to part 1 for whatever reason, go back and do that. And until next time, I'm Nick Peters, and this is Pharmacy to Dose, the Critical Care Podcast.